the third time for those of you that were super punctual and got on right at 2:30. My name is Lauren Rabinowitz, and I'm here with my colleague Kate Wasserman. Kate, you want to say hi? Excited to be with everyone today for our early childhood learning community. So happy to see so many folks on. I mentioned this a moment ago. I'm just going to say it again. We're having a few little technical and presenter challenges due to some weather here in the DC, Baltimore area. And I am sure we have folks on from the Midwest that are dealing with incredible sub-zero temperatures. And so our 1 inch of snow is probably not very impressive to you, but it is makes for difficult travel for us here in DC. But at any rate, we are just going to move on. And once again, we are so excited to have you all on for our learning community today. So I'm just going to talk very briefly about this learning community opportunity as a whole. I'm sure some of you have been with us before. For some of you, it might be your first time, and we are excited to have you regardless. So this early childhood system of care learning community is hosted by the TA Network, and so there has traditionally been a pretty strong focus on systems of care, and though we absolutely are still very committed to systems of care, we're also really excited to welcome folks from all spheres of the early childhood world. So hopefully you will enjoy some of the information that you learned about today and then spread this information to your colleagues. We are excited to welcome folks from the home visiting world, early intervention, child welfare, you name it. We want to get everyone working together. So our goal is to address important topic areas and to try and make this as interactive as possible. We do have a big group, so we won't have the lines will be muted, but please use the chat feature. Thank you to all that are typing in right now. Excuse me. And so we will, so that's our goal, is to be interactive, and really at the end of the day, just in a sentence, the point of this learning community is for you all to get answers to questions that you're struggling with. We'd love this to also be a space where you can share successes, ask questions of your colleagues, brainstorm, etc. This is really an open space, and we are still exploring different ways to make this time really meaningful. So if you have thoughts or reflections, please do let us know. And we will have an evaluation survey at the end, and we would love it if you can please click that link at the end and let us know your thoughts, and we will make sure to address it as we move forward for next month's learning community. Okay, so for our agenda today, we are going to quickly review systems of care and early childhood in that intersection, and then we have some fantastic speakers for you today from Colorado and from Rhode Island, and then we're going to have some time for group discussion and peer learning. And once again, any questions that you might have or any technical issues, please go ahead and put it into the chat. Again, everyone's lines are muted, but that does not mean that we won't be very able to verbalize your questions. So if you have anything, oh, I see one person has lost audio. Please let us know if anyone else did. Perhaps the weather is just impacting things everywhere else. So again, let us know if you're having any technical issues, and we will keep moving on. Okay, so our presenters today, Neil Horn is Zundell from Colorado, and Sarah Remington and Emily Eisenstein from Rhode Island.
Thanks for letting me sort of start us off here. And this is really, I'll just take like 10, 15 minutes to give the big picture, to give a broad overview of why we want to talk about early childhood systems and what are sort of the components that people need to be keeping in mind when we're thinking about this. So I'll talk a bit about what an approach to early childhood systems look like, to really think about interventions and how those fit into the system. And then how do states figure this out? How do they fit? And really in the end, what we're hoping everyone who's doing this work can do is to start to think about that low-hanging fruit at a community level, at a state, territorial, tribal level. What is it that I could start with? So, building an early childhood system takes quite a long time, and as we'll discuss, is a really complex undertaking. And so to just start to figure out, what can I do? Not wow, this is too big, I can't do it, but to really start with what can I do and figure what that low-hanging fruit is will be really helpful. I say all of that because this is what mental health looks like. This is something that I stole, as you see. I'm just promoting, but it really is a way of starting to think about how many sort of connections, what kind of thinking has to go into this. This is not an exhaustive picture of what systems look like, but I put this up there because when I think about early childhood mental health and early childhood systems in general, it really is about a public health approach, and it really is starting to think about all the different places where young children are. The difference, quite honestly, as a starting point for everyone to think about is that young children are not in one place. If you're 7 or 8 years old, generally we can find you during the week. You're in school. But if you're 3 years old, you could be in school. You could be in a pre-K program. You could be in early care and education. Could be in licensed care. Could be in unlicensed or family, friend, and neighbor care. You could be in a doctor's office for a well child checkup. You could be at home. You could be in any variety of places. You could be at Head Start. You could have a home visitor coming. And so it's not a sort of a captive audience. And so starting to think about, well, where are young children and their families? And here's all the different places that they might be interacting with. And when you're building your system, starting to think about, do I know all of these folks? Are these connections being made? And how am I facilitating those connections, strengthening them, and making it easier for young children and their families to move through the system? In our work in systems with older children, we tend to think about them as involved in multiple systems, having a long history of working with many of those systems. In early childhood, quite honestly, we may have people who are the only place that they interact with any sort of formal system is they go to their OBGYN or they go to their pediatrician, and that's it. And they're not involved in multiple systems, and quite honestly, they're pretty happy with how things are going. So thinking about it in that way, and as I'll show you, thinking about all children, not just children who are having difficulty, certainly not just children who are up to the level where they have a diagnosis is really important, and keeping in mind that this is what it looks like is really going to be helpful. Here's a nicer way of trying to put that together, and this is really how we think about early childhood systems of care. And as you see, in the top building blocks there are services and supports, and those are where evidence-based practices for young children and their families are part of a system much like any other system for any age of children. You'll see that we talk about services for children and for very young children that oftentimes takes it looks like young children and their caregivers. We don't tend to put 1-year-olds on the couch and say, tell me about your dreams, and then do therapy. We have a much more dyadic approach to that. But these services and supports vary from system to system, from community to community, but they are part of it. But underneath them are really the pieces that you need to be thinking about in building up your system. And as we think about, even if you're moving from, hey, we have a pretty good system, we've been serving older children, and now we really want to start to enhance how we approach our work with young children, these pieces here are important to keep in mind. They probably don't look very different from work that folks have done, except there are some differences here. So strategic planning policies and procedures are certainly similar to whatever work you'd be doing, but that and those interagency partnerships are probably going to look different because of different players. As I mentioned, Head Start, primary care, the early care and education, home visiting are the major players. Early intervention Part C are the major players in an early childhood system. And so starting to think about, why is it different? The funding that comes in that serves young children is going to look different, as is the workforce. And then the measurement of those outcomes and the evaluation of all that is important. What you also see here underneath all of this is that when we think about early childhood systems, we do not focus nearly as much on treatment or intervention as we do on promotion and prevention. Quite honestly, many of the partners in early childhood are going to be much more focused on promotion and prevention, not about diagnosing, but actually about helping children and their families avoid getting a diagnosis. And so it is a different way of approaching how we even work with young children and families. It's not that we don't diagnose young children. There's actually an entire diagnostic and classification system from 0 to 3 called the DC 0 to 5R, and it's a much more appropriate way of thinking about diagnosis. It's more that we don't immediately go to that. There are evidence-based practices in terms of treatments, but there are also evidence-based practices in terms of promotion and prevention that we push just as much, and we'll talk a little bit about that. And then you'll see in terms of the values, they're quite similar, and they should be pretty familiar to all of you if you're working in systems of care. So as we think about the rest of our learning community and how we'll be approaching our sessions, it's important to think about some of these that I just mentioned in terms of those policy and partnership changes, because those partnerships are critical. There's not big long-term funding streams that are really flexible in the early childhood world. There are funding streams certainly around use of Head Start dollars or McV, the Maternal Infant Early Childhood Home Visiting Program. There are a number of different sources. They are very much earmarked towards that work. And so being creative in terms of financing and policy and partnership is important. Thinking about the services and supports, and what we usually find when we run around the country and talk to folks is that those early childhood systems tend to have some services and supports. And generally, most systems say, there's more things that we actually need to build. And that is dependent on those financing strategies as well as the development of the workforce. I joke oftentimes that there's not a bus full of early childhood PhD folks hiding somewhere. They just haven't shown up. It really is about how do we grow the workforce and how do we think about what do we need a workforce to do. And if you think that in early childhood systems, it's much more about prevention and promotion. For mental health folks, that may be a bit of a shift who are used to, I do billable clinical hours so I can bill Medicaid for a diagnosed condition. It's going to look different. And part of that also is, can you communicate effectively? Can you message about early childhood mental health, which has proven pretty challenging. There's actually, James Heckman won a Nobel Prize showing the cost-benefit savings of intervening early in children's lives, and yet that doesn't seem to have penetrated how we start to spend our money. We still tend not to spend nearly as much money on early childhood. So these core strategies are really critical because we'll be coming back to them throughout our learning community. Okay, so one example of this is the pyramid model, which some may know as the social emotional foundations for early learning, but it is a way, and I apologize that this keeps flipping back and forth, but for some reason it's some animation piece that of course I'm not qualified to fix, but this is really a way of thinking about how do we do at all levels, promotion, prevention, children at risk, children with challenging behavior. How do we address that in a way that can be for staff or our workforce, really help them understand all the different levels of how to intervene. So also to think about in terms of promotion and prevention and treatment, there are evidence-based practices. Here's some examples. So parent-child interaction therapy or the incredible years or trauma-focused cognitive behavioral therapy are all evidence-based practices. Mental health consultation is more of a promising practice. We have lots of outcome measurement that indicates it's a critical part of your services and supports, but it is not a treatment. That is really a prevention type of intervention. So thinking about those services and supports as running the gamut from promotion through intervention is really critical. In terms of financing, it is important that you understand that these are but some examples of those funding streams, but knowing what those funding streams are, and Charlie Bruner and Kay Johnson did a great job of, and I have the reference here for you, to start to think about what are the kinds of funding streams that you should be looking at. And the CCDBG, the Child Care Development Block Grant, is a relatively innovative way of thinking about how people are financing things like mental health consultation. EPSDT, as I mentioned, early periodic screening, diagnosis, and treatment is another one that tends to be underutilized. Young children are going in for well child checkups. There are ways in which we can enhance how we're assessing and dealing with mental health issues through that sort of funding stream. The other piece is it really does require a number of other pieces that are quite familiar to you in terms of a competent workforce. There are competencies built up. There are endorsements and different ways in which states across the country have thought about how to identify who's qualified to provide services for young children. We know that in the last 15 years, there's been a big growth in terms of how many evidence-based practices there are, as well as thinking about what works for a community, what works for a territory or a tribal nation that is going to provide those kinds of outcomes, and not just picking something because it's on a list that says it's an EBP. And that gets to this next point around cultural and linguistic competent practices. All the core values of system of care obviously apply. And then really doing that good evaluation and outcome measurement to say, what do we need to tweak? Some of the most successful early childhood systems across the country have been the ones that have really done a great job of continuous quality improvement, really good measurement of their outcomes, because that's what's going to sell to funders. And then leadership. You have to have some sort of leadership at a state or tribal, territorial, or community level that gets at, here's the intervention, here's who's doing it, here's how we're paying for it, and here's how we're going to sustain it. Again, that's not different for early childhood systems. It's just, broadly it's not different, but for early childhood systems, it's different in the sense of who are those leaders and which system do they come from. Sometimes it's your Head Start collaboration director at the state level. Sometimes it's your maternal, infant, early childhood home visiting lead. Sometimes there's an early childhood advisory council at the state level, or other sort of child focused groups at state, tribal, or territorial levels. But knowing who those leaders are and what the vision is for the system is critical. And then I sort of leave you with the big view. I think when Claudia talks, I've seen Claudia talk many times, and I always love seeing the pictures of the Colorado mountains. Here's a different perspective, looking up and looking down, like in your state, in your community, in your tribal nation or your territory, how are you doing in terms of the EBPs for early childhood? What are the challenges? Where's the knots in the system, as Doreen Kavanaugh, one of my colleagues, oftentimes says? Where's the workforce? And how are you starting to think about things like competencies, the pyramid model, or Alliance for the Advancement of Infant and Early Childhood Mental Health have endorsements. Mental health consultation has a federally identified set of competencies. Where are all of these, and how are you assessing all these various components within your community, territory, tribal, nation, state? It's really important. And I think that when you hear folks like Claudia from Colorado or the folks from Rhode Island talk today, what you'll hear is that they've actually been addressing these sorts of things. So I didn't want to take too much time, so I'll turn it over to Claudia.
Kate, who will introduce Claudia. If she has audio.
No, I'm on, right?
Yes, there you are.
Great. We're really pleased and appreciative for Claudia to give her time today to speak to you all and to us together about really her career's work, which has really moved the state of Colorado far. So I'll let her talk more about the specific projects, but just to give you guys a brief bio about who she is and what she's meant to this field. She has been working in human services for over 20 years. She worked for the Colorado Governor's Office for Children for 4 years, and then at the Department of Human Services, which has employed her since 1991. So they know how to keep good people. She served as a developer and director of Colorado Family Centers for 10 years. And Claudia has served as the director for the Children's Health and Rehabilitation Services for her state, and was appointed to manager of early childhood mental health programs within the Division of Behavioral Health Services. She served as a principal investigator for several grants that she'll talk about today related to early childhood mental health, including Project Bloom, which was the first system of care grant in the nation to explicitly focus on young children. So you can imagine right there why we were so appreciative of her time and expertise. And Claudia, I hand over the slides and microphone to you.
Thank you so much. Good afternoon, everyone. Before we get started, I just have to say that Colorado got 3 to 8 inches, and we're still moving. But anyway.
Fair enough.
What's really fun for me is that I'm able to talk to you from a long perspective about this work. We started really getting serious about early childhood mental health in 2000. And at that time, we did not have a lot going on. And you can see the picture of the mountain there on the left, and that was our desire to get to this peak of early childhood mental health activities. But we had some pilots that were authorized in legislation that were called the Consolidated Child Care Pilots. And the purpose of those pilots was to bring together different early learning and education programs. But what those pilots had was the ability to request waivers of state law. And so that became important as we began to build our early childhood mental health work. At the same time, we also had a couple pilots for mental health early intervention. And at that time, the approach we took was to do some mental health consultation. So at the beginning, our work was really trying to organize who was really interested in early childhood mental health. And one of our key events was in 2000, in the middle of a snowstorm, by the way, on Valentine's Day. We invited everyone we could think of that might be interested in early childhood. And it was the first time that this group of people have gotten together, and it was comprised of people from the child care world, people from the mental health centers and providers, and people from the universities. We had a really strong university group that was very interested in early childhood and were national leaders, but it was the first time that that group all got together. And in the middle of the snowstorm, 100 people still managed to get out and to come to this event. And so we knew at that point that this was really important for the state of Colorado. We've evolved to the point where we now have an Office of Early Childhood, and that office contains both the early learning and education kind of activities, the licensing, and the mental health, the early childhood mental health activities. So another thing that was really important, you heard some discussion about leadership, was to have leadership at every level. And I will tell you that we struggled with this over the years to really get that highest level of leadership. Those consolidated child care pilots were turned into a formal program known as the Early Childhood Councils, and they became a very solid foundation of the coordination at a local level. The middle level, which was mid-level managers, people that were running programs, that was a very strong group that stuck together over a lot of variations. They were advisory groups, they were collective impact. There were many different variations of what that group looked like, but there was a core that really maintained their focus on early childhood, including early childhood mental health. When we got our SAMHSA grant in 2002 for Project Bloom, we decided that we also needed a group that could explicitly focus on the mental health piece. And so we created a Blue Ribbon Policy Council, and that group, we'll talk a little bit more, but that group came up with a state plan that I have to say in some ways is still guiding our work today. So this was a very important piece for us as well. We call this the Early Childhood Framework. And at one point, this work has lasted over 4 governors. And I will say that most of the governors have been very supportive, but there was one where we kind of just had to hang in there. So over 4 governors, we've been able to continue this work. And part of the decision we made in Colorado around our mental health work was that we wanted to be part of the early childhood system. So rather than embed this entirely in the mental health system or some other system, it made sense that we were part of this bigger effort to coordinate early childhood. And so a framework was developed by one of our lieutenant governors who was really involved in early childhood. And what was so nice about that framework is it had really a couple pillars of work. So there was the early learning of education, there was health, there was the mental health, and then there was family support and parent education. And having that framework really helped consolidate all the different disciplines that were part of this early childhood work. What you see in front of you is an updated, much more modern version of this framework. And I also put the link there for you. But this was a way that we could coordinate between local and state and across different program areas. And this has been very, very helpful for people to find themselves in the early childhood work. So I mentioned to you that one of the things we did was establish a Blue Ribbon Policy Council to really set some goals for what we needed to do in early childhood mental health. And these were the 5 different areas that we set goals in: public engagement, professional workforce development, funding and finance, programs and services, and then we used a bucket of system of care to talk about our interaction and connection with other program areas. And what you can see at the bottom of this slide is a more updated version, a policy paper that really also talks about some of these same areas, but it's our more updated plan. So in terms of the programs that we really focused on, we had a big focus on mental health consultation, and we also did a substantial work on screening and really encouraging physicians to screen, for there to be screening in child care settings. And one of the things we did early on is we thought that, we could come up with one screening tool that could work, but it was pretty clear that the different environments required different screening tools. And so we came up with a paper that there's a link to it right there, that identified the different screening tools that would be appropriate in different settings. And that was very helpful to guide people in child care settings, in doctors' offices, and in other locations. And then we did focus a lot of work on really developing our early childhood clinicians and giving them lots of training, lots of support to work in the early childhood space. I'll talk a little bit more specifically about some of the programs and trainings that we brought to them. And then one of the things that was challenging, and I'm sure people experience this, is when we got our System of Care grant, there's supposed to be a focus on children with serious issues. And in early childhood, that was hard to get people to buy into. And so one of the metaphors, you might wonder why there's a picture of a truck, but one of the metaphors that we came up with was that we had to use this grant to build some foundations. And just like when you build the roads so that the heaviest trucks can go on them, and then all the cars can use the roads as well. And so that's how we began to see the opportunity that was provided to us with the System of Care grant, was that we could lay down that foundation and then also serve children in a prevention and promotion fashion as well. So this is our pyramid. So the dark blue is really sort of the promotion and prevention as you move up the triangle, with the red piece being the intervention or those children that have serious issues. And we outlined these key strategies that we thought really, for the most part, cut across those different levels, although there were some, of course, when you got to therapeutic services and supports that really fit more in the intervention space. But this was our way to lay out those different strategies and at what level they existed. So I mentioned that mental health consultation was something we really took on. we were very fortunate to get some legislation passed that allowed us to have an early childhood specialist that was located in each one of our public mental health centers. So that was 17 across the state. However, in recent years, we've been very fortunate to be able to double that number and use some child care development block grant to increase the number of mental health consultants across the state. And so that provided a very nice foundation of mental health consultation, although at the same time Head Start and other programs were also employing mental health consultants. And so where we are now is we are working with some foundations to create a training and technical assistance hub for mental health consultation. And I would just point out to you that one of the things we worked very hard on throughout time was getting good data about the results of mental health consultation. And currently, the data that's cited is that we have a 66% reduction in risk of expulsion. So there were 3 ways that we tried to measure our impact for mental health consultation. What you see on the screen is a comparison between 2 different projects related to mental health consultation. So the first thing we looked at was what was our program reach. So how many providers were we reaching and how many children. And you can see that went up markedly through the years. And then the other thing we grappled with was how could we show the need for the program. And so when we looked, however, at how many children in those settings had a social emotional delay, it's a very small percentage. And so this was not necessarily a striking endorsement of the need for mental health consultation, although certainly by screening a lot of children, we were able to reach at a very early stage some of those children that needed a more intense intervention. And then one of our funders, one of the foundation funders, really said to us, you need to have some measure that talks about how you're impacting the child care environment. And so we started to use the preschool mental health climate scale and found that that was a very helpful tool for 2 reasons. One, we were able to show quite a bit of change. In fact, on all 9 scales, we were able to see improvement. And it also helped the consultants organize their work. So when they did the preschool climate scale the first time, it helped them figure out where were some areas that they could intervene. And then when they repeated it 4 months later, they could see if there was an impact. So a little bit about some of the other programs that we worked very closely with. I'm going to talk a little bit more about Part C, and TANF was an area that we were able to find some funding, some unexpected funding, by making the case that mental health consultation was really helping parents be able to work, because many times we know if children are having difficulties at child care, the parents would be called to take them home. And then certainly we talked about the early childhood councils, and I'll talk a little bit more about Launch Together, and then ABCD, which was our screening initiative in primary care offices. So Early Intervention Colorado is our Part C program, and we were able to work with them, I think, in a couple of very important ways. We were able to take wraparound and incorporate it into the family support plan. What we did is we looked at a number of plans that were used in early childhood and found out, in fact, the early intervention family support plan was the most similar to a wraparound plan, and that there were only a few more components needed. So we were able to integrate those 2 plans. We were also able to get our Part C agency to use the DC 0 to 3 as eligibility for early intervention. So we had our professionals at university review that and say these are the diagnoses that would qualify somebody for early intervention. They also renamed the social work intervention to social and emotional to recognize those kind of interventions. And then certainly we served on interagency coordinating councils.
Claudia, can I ask you a quick question related to that? Your work
Sure.
with Part C?
Sure.
Can you talk a little bit about any of the sort of training or support that you gave to the workforce so that they felt comfortable with using the DC 0 to 3R?
Well, yes. So we trained extensively our clinicians to use it. We also worked with Part C on the pyramid model, so that they shared in those kind of trainings. And just recently, we've launched a training of trainers for DC 0 to 3R so that we can have more trainers across the state, because we've been really relying on the university for that training. But all of the early childhood specialists that I mentioned, they're all trained in the DC 0 to 3R.
Great. Thank you.
Sure. And then Launch, I think people may be familiar with Project Launch, which was a grant put out by SAMHSA to, there's several components, but part of it is to incorporate early childhood mental health with primary care. We were fortunate to receive a grant, and then what happened, which was so interesting, all along the way we've been talking to our foundations, and they've been supporting us. They've been great partners. And they decided to build on Project Launch. They loved that model, and they created something called Launch Together. And so then they put in $12 million, and we were able to fund many other communities to implement the Project Launch model. And there was a sort of an intermediary nonprofit called Early Milestones that was developed. And what you see here is a lovely video that they put together to really explain what Launch Together is and why it's important. And so you have the link here and you can watch that. And so in terms of funding, certainly having good partners leads to additional funding. And one of the things we did too was we looked at all of the federal funding streams that we could think of and identified where there would be potential for early childhood mental health services. And so then we were able to share that with communities. And there were many more funding sources than might be readily apparent, but it took a lot of work to help communities really see how they could tap into some of those funding streams. And then TANF, I mentioned we had an opportunity to utilize some TANF funding, which continued for some time. And then I would just finish by saying we kind of reached a mountaintop, and that's me climbing my first 14,000-foot mountain. And I leave you with a quote that one of our evaluators came up with, who was just so impressed by this work. We did a study, in fact, a cost of failure study, where we were able to demonstrate so clearly that this early intervention made a big difference. And this is her quote, and I just like to end with that, because if even the evaluator came on board, we were making progress. Thank you.
Claudia, thank you so much for that presentation. It's amazing to see this incredible work Colorado has been engaged with for so long. Any questions for Claudia? You can go ahead and type them in, and if they come to you during the remainder of the presentation, that is completely fine as well, but we can pause for just a moment and see if anyone has any questions for Claudia. Okay, and if not, that is completely fine as well. Feel free to be chatting in as we continue on. So I am really excited now to introduce our next two speakers from Rhode Island. I think this is a really nice example of system of care work. So I spend part of my time in the home visiting world as a TA specialist with the HV Impact program. So that's the Federal Technical Assistance Center for Home Visiting. And so I first came to know about some of the great work that's happening in Rhode Island through that project. But when we were planning for this webinar, it just immediately came to mind as what a perfect fit it would be. So I'm going to introduce Emily and Sarah. So Emily Eisenstein has been with the Rhode Island Department of Health in the perinatal and early childhood health team since September 2009. Currently, she is managing Rhode Island's Project Launch Grant. Before this, Emily managed the Screening to Succeed project, which was part of the Department of Health's work on the Race to the Top Early Learning Challenge project. And as part of that work, Emily and her team assisted over 35 primary care practices in integrating standardized electronic developmental screening into their workflow. Emily's first position with the Rhode Island Department of Health was with the WIC program as the state breastfeeding coordinator, and that was a position that required her to plan and coordinate statewide breastfeeding promotion efforts. And originally from Nashville, Tennessee, Emily received her Bachelor of Arts from the University of Pennsylvania and her Master of Public Health degree from Temple University. And her partner in crime, Sarah Remington, is the implementation manager for the Rhode Island Department of Health's Family Visiting Team and has been with the program since its inception in 2010. Sarah is responsible for the 9 Healthy Family America sites statewide and supports the Nurse Family Partnership Team as well. She has participated in multiple phases of HV COIN, so that's quality improvement work, and currently serves as an improvement advisor for the current HV COIN project. So thank you so much, Sarah and Emily. Take it away.
Okay, great. Thanks so much, Lauren. We're happy to be here. Can you hear us okay?
Yeah, you sound great.
Okay, perfect. So I think what we'll just kind of add to at the beginning is a little bit about what we do, and then we'll dive right into the slides. So Lauren, thanks so much for introducing us. Like Lauren said, I work on Project Launch at the Department of Health, and we are currently in our last year of our expansion grant, which we had an original launch grant that ended, and now we are finishing up our expansion grant. So we're working in 3 different communities in Rhode Island, Woonsocket, which is in the northern part of the state, South County, which is the beaches, kind of the southern part of the state, and then Newport, which I think most people have heard of. And we're working basically doing different strategies in all 3 communities, Incredible Years parenting programs, mental health consultation in pediatric primary care offices, and then mental health consultation in early care and education settings as well. And I'll let Sarah talk a little bit about what she does, but she and I are fortunate to sit in the same office. We have a lovely carpeted wall in between us, and we yell at each other across the way. So it's nice to have her so close so we can work together. Sarah, you want to go ahead?
So my name is Sarah Remington, and like Emily and Lauren kindly mentioned, I'm the implementation manager for the Family Visiting Program. We started off very small with MIGV funding. Healthy Families was new to Rhode Island. But we did have a very small nurse-family partnership program and some school department-funded parents as teachers program. And we have now expanded where we are serving 1,400 families in MIGV across Rhode Island, which for us is pretty significant. We also have a short-term home visiting, family visiting program called First Connections, which is a statewide short-term linkage and referral program. So Emily and I are always working on opportunities for collaboration and the overlap between our 2 different systems of care. And family visiting and the work with Project Launch certainly lend themselves to ongoing collaboration. And so we're going to talk with you a little bit about what we do and how we've been able to kind of carve out some opportunities for ourselves and be purposeful in our collaboration efforts.
Great, thanks, Sarah. So this is Emily again. I think we started to, I know Sarah's been working with Lauren for quite a while, but Sarah and I started to work with Lauren together when we realized through the Department of Health that we could apply for some MCH Title V funds to really work on family engagement. We, through Project Launch and through family visiting, we need parents that participate with us, give us feedback on launch, give us feedback on family visiting, and we realized that sort of throughout our work, we don't have enough of that, and we needed some help to have that happen. So we requested some funds, like I said, and I'm going to kind of skip around a little bit through the slides. I'll kind of scroll forward here. Basically, we applied to have some funds to go to Ohio to learn how to run effective parent advisory councils. So we went to a one-day training in October, which was super helpful. And we're in the process of really trying to develop that council right now with Lauren's help. We also asked for some funds to implement a parent cafe model as well in a couple of our communities. Like I said, we have parents that participate with us, but they tend to be parents that are employed by some parent information network, parent support networks. So they're parents, but they're working parents, and we really wanted true parent involvement to give us feedback about both of our programs. So it's been really great to work on this together. Sarah, anything you would add to that?
No, just as Emily mentioned, a lot of times we are asked for parent input into some of the initiatives that we're working on, whether it be marketing and PR or other policy types of issues. And I know one of the challenges and frustrations for us is that we were kind of told to go get parents and get their input, and really did not have a formalized mechanism for doing so. We are wrapping up a 5-year strategic planning process, and parent involvement and family involvement in that was critical. And while we wrote into our plan for the strategic plan that we had to involve parents and certainly wanted to, we didn't really have a plan in place for doing so. So as Emily mentioned, when this venture capital money came up, or this MCH money came up, it was really a unique opportunity for us to take a step back and say, what do we need to accomplish, and how can we use this funding to accomplish it?
Great. So the other area that we work on is an advisory committee called Successful Start. Sarah, do you want to talk a little bit about that?
Sure. So we have an early childhood comprehensive systems governing body called Successful Start, and it has lived and had ownership through the health department since its inception. And one of our bosses has typically chaired that group or committee. The group kind of waned off for a little bit. It was not meeting quite as regularly, and attendance is kind of waning. So Emily and I were able to talk internally with folks and get some energy behind reinvigorating that board and that group. And we have now have been co-facilitating the Successful Start group. And in turn, that group has kind of turned into an advisory body or a grant body for some other projects as well, including our child welfare agency called DCYF. They are using Successful Start as an advisory group for one of their Getting to Kindergarten grants. We also have folks, a wide representation of people on that Successful Start group, including members of the American Academy of Pediatrics, our own medical director from the Department of Health, as well as parent groups, representatives from our different agencies and service providers, school departments, and other early childhood and maternal health organizations. That group also serves as the advisory board for some of our Parents as Teachers and Healthy Families America sites as well.
And the other area in which Sarah and I do a lot of coordination and where we spend a lot of time kind of yelling back and forth in our internal office is essentially we have a referral system here. I'm sorry, I'm skipping around to the slides. Let's see, here we go. that we share. So when the Department of Health received some funding through the Race to the Top Early Learning Challenge work, and we started to work with pediatric primary care practices on developmental and social-emotional screening, we realized that providers may not know exactly where to send families for support or how to get it there. So we established a referral line where providers could send referrals either through a secure fax line or over a voicemail system, and we would help link families up with services. So, for instance, a child goes in to have a well-child check. The parent completes a developmental screen. The screen that we're using is the SWIC, the Survey of Well-Being of Young Children. That also has a social-emotional component, an autism component, some other questions about the family as well. So the parent completes it. There's some concerns, development, behavioral, that sort of thing. The provider can actually send the referral directly to us through our referral line, and we will help link the family up with services. So Sarah and I work really closely on that. It's a referral line both for our pediatric primary care providers, but also for families or for families that are interested in just straight family visiting. But often what happens is we get referrals from pediatric primary care providers, and the families actually could benefit from family visiting. So we'll work together to figure out both if the family is already in family visiting, and if there's another concern that needs to be addressed by the family visitor that's already in there, we can, Sarah can quickly get that message over to the family visitor, or if the family could really benefit from family visiting, we can easily send the referral over that way. So it's a really nice way of coordinating services and making sure that the family is getting where they need to be and we're not duplicating services at the same time. Sarah, anything you want to add to that?
And this is Lauren. I'm just going to pop in real quickly, Sarah and Emily. There's a question. Someone's asking for how you all are defining family visitor.
A family visitor to us is someone that is a family support specialist, a nurse home visitor, or a parent educator, or one of our nurses in our First Connections program.
And do you want to maybe just also talk super briefly about how Rhode Island came to rename, because you did a pretty significant rebranding effort for that, right?
Sure. So I think about 3 to 4 years ago, time flies, we were really taking a look at our data and realized that we had an issue with referral and engagement. We were not meeting our McBee goals for enrollment, for referral and enrollment, and contracted with an outside marketing firm to really do a site scan with both potential referral sources and with families about lack of engagement, whether on the provider side or with families. And after a series of focus groups, one of the biggest things that came up is that families thought we were child welfare and actually didn't like the term home visiting. There was a whole host of ranges. People didn't want to do their dishes and clean their homes. Some people did not have what they perceived a home for a visitor to go to, and it was really stigmatizing. So we launched a new campaign with this marketing firm called Love That Baby that some people I know have seen, and rebranded home visiting to family visiting. So we call our home visitors family visitors in a broad term. Obviously, we're respectful of every model and what they call their specific home visitor, but when we're speaking in broad terms in Rhode Island, we call our staff family visitors.
This is Kate. That's so interesting. I mean, it sounds like a trend in both your state story and what Claudia was sharing about Colorado is that there was some intentional data-informed decision making that resulted in some rebranding of what the sort of mental health workers or teams or whatever you want to call them were called. And I'm wondering if any of our participants have questions about that or have thoughts about how that goes. I often joke when sharing many of the funny-sounding acronyms in the world of early childhood that we're clinicians and not marketers. So, I think we would often benefit from pulling in some expertise in sort of marketing and messaging around what we're trying to do with families.
Yeah, and this is Lauren, just to kind of piggyback on that. I was hearing that same theme when Claudia was talking, and this again, and I just jotted this in the comments. But it's pretty interesting that we think about Colorado and Rhode Island. Those are two pretty different states in lots of ways. But when we think about these early childhood system issues, they really transcend lots of different populations and local conditions and context.
And I know Emily was talking about the referral component, and I can't emphasize how important that is for us because, yes, we are a small state, but we are able to link families more intentionally to both family visiting and to other supportive services like early intervention. So having that referral line, and we also have a no wrong door approach with our family visiting program. So if a provider wants to fax it to an agency in their community, great. We trust that if it's a referral to NFP and then they're not sending it to the Nurse Family Partnership Agency, that the agency will get it to the right Nurse Family Partnership site. So we also have providers that just want to send their referrals over to us, and I do the sorting, or my teammates do the sorting and get them to the right agency. But we'll connect with Emily and her team to make sure that, if there's a developmental screening that there's a concern about, that we're also being intentional in making that referral to early intervention and to other supportive programs.
I think we're also really lucky in Rhode Island. We have a system called KidsNet, which is basically a registry of basically births in Rhode Island, and it includes information about early intervention, WIC, family visiting. It has developmental screening information about hearing screens that have been done. And so when we get a referral from a doctor, we can look, or a referral for family visiting, we can look and see if the family is connected with WIC, and if they're not, offer that as well. Look to see if they, might need a hearing screen, and really help get families connected with other resources as well, which can be nice.
And so is that just like the culture of your lovely state? Or because what we often hear is that there's a lot of because so many of these programs are driven by referrals or county numbers for grants or expectations, that, sharing families or getting families to the right door can often be well-intended but not always what happens on the ground. So how have you guys been able to sort of facilitate that relationship?
I feel like you've done a great job with that through family visiting. Do you want to talk a little bit about sort of, because that's something you've been working on, it seems to me.
I mean, I think we do have the luxury, unlike some of our colleagues in Colorado, that we are small. So we bump into each other literally almost every day. So our Part C coordinator actually used to work in home visiting or family visiting. We all kind of know about each other's system of supports, and we're also very intentional about the work that we do across programs and across agencies and state departments. So we actually, when McVie came about, we actually started meeting once a month with some of our sister state departments, and those are working meetings. So those are, how do we coordinate professional development? What training opportunities are out there? What are the barriers in communities to engagement? Our Part C coordinator recently did what we call the roadshow. She came out to different community meetings with me and talked to the family visitors and was like, okay, we're going to do a refresher on what early intervention is and isn't, and did some barrier busting. So what's working well, what's not working well? And so I think we try to model at the top what we want to see in the field with that ongoing collaboration.
That's great. That's super helpful. I was just curious, Claudia, if you had any kind of reflections on that coming from such a larger state that I know has a lot of local control.
Yeah, I think so. Some of our work was certainly at the state level, but obviously a lot of things actually get delivered locally. So that's another way that those local early childhood councils were so valuable to us, because they cover almost every county, and that's the group of people that are really interested in early childhood. So that was a great method for coordination. In some cases, they connected to their local interagency coordinating council for Part C. But in other cases, they at least had a relationship and a connection.
And that may be where our size comes to our advantage because we only have one interagency coordinating council in Rhode Island.
Sorry, Sarah and Emily, to have usurped your presentation. I think you still have some slides left, so continue on.
That's okay.
It's really interesting.
So I think, yeah, we only have one more slide about sort of our work with mental health consultation. We both are focused on mental health consultation, and like I said, in Project Launch, we have mental health consultants in primary care practices, as well as doing some mental health consultation in early care and education settings. And that's something that family visiting is also focused on, so we're able to share resources and work together. And I think it's, like Sarah said, kind of being a small state, working closely together. We have one state health department. We don't have local health departments, so it can be really nice. Sarah, anything you want to add to that part?
I mean, we're lucky that we work with a lot of the same mental health consultants, too. Family Visiting just put together, with Lauren's assistance, a framework for mental health consultation within Family Visiting. And Emily's been part of that process, and how we have developed this framework has involved a lot of input. But again, there's a lot of shared partners, so we're able to see what her program is doing, what Family Visiting's goals are, and align that work together.
This is Kate. I think one of the things that we're trying to sort of intentionally focus on throughout the course of this year as well is the idea of really elevating family voice in early childhood systems. And so I'm wondering if you guys have seen any trends in, the families that end up, becoming more of your sort of leadership families, or what we can learn from the work that you guys have moved on ahead with that.
Sure. So we are somewhat in our infancy of developing that parent voice at the leadership level.
I think the field is, so that's totally okay.
Yeah, we are, we have a work plan and definitely some timeline goals for getting parents building that leadership capacity. We're also driven in part by the current COIN work that we're doing, home visiting COIN work that we're doing on maternal depression, where parent leadership and a parent voice is required as part of that. And so we're trying to be very intentional, but also not force something to happen too fast and not support parents as effectively as we should be.
Yeah.
Yeah, I would think I agree. It's been kind of a challenge. We were fortunate to send a couple of parents to D.C. last February, actually, to SAMHSA held I'm not going to think of the right term, but sort of a family engagement type of summit. And we sent a couple of parents, and I think it was challenging because we hadn't done enough pre-work to really be able to fit them in, sort of find their place. I'm not saying it very well, but to sort of know how to use them in the best way. And so I think stepping back and really going to this training that Sarah and I did in Ohio and really starting to think about how to build an effective parent advisory committee will be really helpful.
So it sounds like we'll just have you guys on in about a year, and you can tell us what you've learned.
Sure.
Well, and I will just say, because I always say this too to Sarah and Emily, that I don't know that you always give yourselves enough credit for the work that you are doing and how dedicated you have been to this effort. I mean, there are folks all over the country that are struggling. Exactly as Kate said, this is not something that I think too many folks say, yeah, we've got this. So the effort and dedication that you all have and continue to put forth is commendable in and of itself. And on the foothills of that, we also have one question that came in from Ashley, and I think either Emily or Sarah could address this. Ashley asks if you could describe your process of getting mental health consultation into pediatric or primary care settings. That's a great question.
Yeah, that was part of Claudia's work too, so if we could hear from all three of you, because it's probably a little bit similar and a little bit different.
Yeah, sure. So I'll start. This is Emily. So it's been kind of a long process, actually. We were fortunate, as I said, to start, but before we got the launch expansion funds, we had some funds through the Race to the Top Early Learning Challenge. Like I said, we were focused on screening, getting providers set up with screening electronically. But as providers, when providers sort of signed on with us and worked with us, we were able to offer some supportive services like the referral line, but we also offered some providers the ability to have a mental health consultant on site. So when Race to the Top ended and we got some funds through Launch Expansion, we had done some of this work. We had some mental health consultants that we had worked with, and in one of the practices that is a launch practice, we were able to really just roll the mental health consultant kind of over to new funding and keep her there. Now, with our mental health consultants through both the Race to the Top work and the launch work, it's unfortunately we don't have a ton of funding, so it's really only having consultants on site for about 4 hours per week. So it's, you know, it would be great to have them a lot more, but we don't have a ton of funding to be able to offer that. So with the one site, we were able to roll the mental health consultant over. With some of our other sites, we really actually kind of changed the process a little bit. With Launch, we really, the goal is really to have the community build capacity. So we had a really great partner in South County, which is the southern part of our state. They identified a couple of different consultants that were interested in doing mental health consultation. We went out and sort of pitched what mental health consultation is to the practices that were in South County, and then a couple of practices were interested, and so we really just worked with those practices to get the consultants on site. We did do some work developing kind of a framework or, you know, a guide for what the consultants would be doing, what was expected as far as, you know, what the consultants are doing, and expected as far as what the practice would be doing. Things like the consultant, at least through Launch, is really doing things that are not billable, so they're really there on site, helping. They're doing kind of short assessments and linking families up with services. And so, you know, that was outlined in the framework, but then we wanted the pediatric providers also to have some sort of roles that they needed to fill or things they needed to do, such as it's really helpful for the consultants to have access to the electronic medical record, or if they're on paper, to be able to enter records into their system so that the providers can really see what was happening, have a space to see families, that sort of thing. So it's been kind of a process, and it's sort of depended on the location and the consultant. And right now we're really working on sustainability because our launch funding is going to wrap up pretty soon. So that's kind of our next step in the process. I don't know if that answers your question, but that's kind of a brief overview.
So I would say in Colorado, part of the foundation really was the screening effort. We did a pretty big push to try to get pediatricians to do developmental screening, including social emotional. And one of the things we were really fortunate about is we had a pediatrician who got very interested in early childhood, and he actually started a whole program called Colorado Child Health Access. And so he was a wonderful advocate to talk to other pediatricians about the value of early childhood development and early childhood mental health. And so having him as a partner was helpful. But the screening really was the foundation, and then locally folks were able to reach out to the particular practices in their area. Sorry, that was Claudia from Colorado.
It looks like that answered the question for Ashley. So great. That is good. Okay. You have a little more content, Emily and Sarah, or are you?
I think Lauren, we're done.
Perfect. Great.
If any other participants have specific questions, we can take those now. You can either type them in or unmute your line. And then we also have want to take advantage of having Neil on the line now. Hopefully his technology will work to unmute him, and we can hear a little bit about, Lauren did a great job with his slides, but a little bit about, his perspective and maybe sort of draw some conclusions over these big themes we talked about so far in the hour.
He wants to keep us hanging, Kate. He just lost his audio, so he is going to dial in again and just keep us on the edge of our seat for a minute.
Okay. So there's a minute or two, however much time it takes to dial a 1-800 number for folks to ask any specific questions. And again, Lauren and I are so appreciative of these sort of, our three speakers today, and it's really fascinating to sort of see some of the trends and similarities, and then some of the things that just happen because of where you are. But
and also why we and while we have a moment, exactly to echo Kate's point, we would love to hear from all of you as well. I do just some thoughts or reactions to what you might be interested in hearing more about. So we are going to be having this learning community monthly moving forward. We used to do it every other month. So we will now be coming together on is it the second or the third Tuesday, Kate?
Well, it's going to dance a little bit. So in February,
right.
It's the 9th, which is the third, and then March forward, it should be the second Tuesday.
Right. Okay. We'll be the second. So, so we are really very, very happy and eager to hear from all of you. If you have thoughts, ideas, what it is that you really want to hear about. As I said in the beginning, this is a space for you all. And please do share it with your, with colleagues and, all those working in the early childhood space.
And hopefully you guys saw, but for February, so the February 19th, that's a Tuesday, same time, same dial-in, same channel. We're going to be having some folks from 0 to 3 talk about their DC 0 to 5. Not necessarily looking at the diagnostics of it, but really how it's helped move some of the state policies forward in a couple of different areas. So we hope you guys can join us for that. And we're going to give Neil one more chance to see if technology is going to work for him.
I can't believe you guys just keep on silencing me. Finally, you let me talk. Yeah. So I'm sorry, folks, that I was unable to join at the beginning. A couple of things just sort of struck me as I listened to Claudia and Sarah and Emily, and one of them is it took you guys a long time. I mean, Claudia's work started, as you hear, with lots of different little pieces, and certainly the System of Care grant was able to sort of bring some of that together. I think Emily and Sarah, I go back to the early System of Care days of Rhode Island with Kathy Ciano and the family movement in Rhode Island and things. And as I listen to where you guys are at, I think it's important for folks to keep in mind that took a lot of work. I mean, the folks in Colorado came to a policy academy with a super excited legislator, and it sort of was part of the impetus that moved that forward. And the System of Care grants for older children in Rhode Island, and eventually the one for younger children, and the involvement of folks who, quite honestly, then were involved in Project Launch. And I think a lot of you are hearing some common themes in building early childhood systems, is that it's not simply you get a federal systems grant and you're done. It's you get those grants and they help keep that momentum going. And a lot of what I heard is really consistent with what we think about when we think about systems building, about trying to think about some of those policy changes, but also those partnerships. And I thought Emily and Sarah did such a nice job, and Claudia, you always do a nice job, but Emily and Sarah did such a nice job of sort of talking about all these different places in the early childhood system where children and families are going to enter. They're going to enter in the early intervention system. They're going to be in a primary care practice, and starting to think about, so how do we meet them where they're at and not keep, not pretend that young children are coming to mental health clinics for every single service is such an important point to keep in mind. So those partnerships and those policy changes are really important to keep in mind. I think the other thing that you heard a lot of was this idea about what's the array of services that you need that's going to be family driven. And again, I loved hearing about the Family Summit that Project Launch did to really try and engage families in the Project Launch family, all those Project Launch communities and states and tribal nations and territories. How do we have families really drive services in the early childhood system? And as Kate mentioned, that I think is a big piece of the work that this learning community is really going to foster, is making sure that we're clear about what family-driven services look like in an early childhood system. And I think that when you think about those array of services, they are going to look different. And so I think that part of what you heard today, and Claudia's and the work in Colorado is such a good example, is I distinctly remember sitting with folks in Colorado, and they made a matrix. They like making matrices and using matrices in Colorado, but they had a matrix that said, here's all the different kinds of training that we think might be helpful, and here's when we're going to do them. We're not just going to just do training because we have money to do training. We're going to thoughtfully select what trainings to do, what EBPs to do, what kinds of services and supports our children and families need. And I think that that's another good example of what it takes to build that system. Is not just, and I see this all the time, when people get some money, they just start bringing in, and I'm not going to demean or dismiss any evidence-based practice, but just bringing in trainers to do whatever is the hot EBP is not necessarily what's going to move your system forward. I think the other thing is the idea of how you pay for all this. And that was the other matrix that, quite honestly, in Colorado and Claudia in particular made effective use of, was to take a financing approach that looked at what are all the potential sources of funds. And a while back in the System of Care work, I think Sheila Pyrates and Ken Martinez and others did a look at how are people using and accessing funds like EPSDT, early periodic screening, detection, and treatment, which are Medicaid dollars that can be accessed and might be helpful in financing parts of your system. But I think that that's a big piece of what you hear in the work that Rhode Island and Colorado did, is they thought very carefully as funds came and went. And Claudia could give you great examples of sort of, and I'm using really cheesy Chris Farley-looking air quotes, finding $1 million that you get to use, but only for a short time, and how do you use that most effectively, and how do you keep moving all the private-public partnership dollars that you can to keep your system moving towards, quite honestly, what I always think about with Claudia is the top of that 14,000-foot peak, is how do we get to where we're trying, what's our vision for what our system's going to look like. All of that really takes a workforce, and that's the thing you hear across the country is, well, we don't have enough master's level, or we don't have enough folks trained in this or that. And I think, again, when I think about two places like Colorado and Rhode Island, their system, and when I think about their system, there's sort of these efforts in home visiting, there's these efforts in mental health consultation, there's these efforts in early care and education. What's the workforce, and what are we trying to do to support the workforce so that wherever children and families are, whether they're in licensed child care, or they're in Head Start, or they're in family, friend, and neighbor care, or they're in center-based, or they're in a doctor's office, that there's a workforce that's actually able to meet their needs. And then the last piece, and in some ways the most important piece, because you saw it live today, you heard it, is having some real strategic communication about your system. And I think that you hear today people like Emily and Sarah, and I think, Lauren, you're right in saying that they sell themselves short, that they've accomplished so much, that these are folks who can really articulate very clearly what it is that they're trying to do. That's going to help you get other folks to be part of what you're trying to do. And quite honestly, in places where there's a strong early childhood system, it's not just one person. It is the leadership of folks like you've heard today, but it's also the leadership of lots of folks across different child-serving agencies that I think when they come together, and quite honestly, in Maryland, there's a great early childhood steering committee. In other places, there's governors' cabinets, there's early learning advisory councils. There's lots of different mechanisms to do this. It's when those are cohesive groups that are clear on what they're trying to build where you start to see some of that movement. So I just wanted to sort of throw out some thoughts. I always like to show up about an hour and a half after I was supposed to show up, and not show any of my slides and just start pontificating. But it was just something that sort of struck me as I listened to you guys. And I've heard Claudia talk many times, and every time I hear it, it just impresses me what they've been able to do. And I'm very well aware of the work in Rhode Island that Emily and Sarah done, and lots of other folks, across lots of different agencies. So I think it's been really interesting to sort of see how you all have, in some ways, without me ever showing a slide about early childhood systems today, have actually done all the work anyway of talking about what that really looks like. So I just want to throw that out there.
Thank you, Neil. I think there's a lot of really poignant themes that you were able to pull out between these systems. And want to just offer, it is almost 4 o'clock, and it is at least a snowy or at least wet afternoon for many folks. So want to just offer folks a little bit more time if they have to ask any questions specific to some points that Neil was drawing or our presenters' examples. Lauren and I will follow up with you guys with the links to register, which TR also put in the public chat, as well as the subscription to the TA Telegram, where you can find out a lot about either news about some things that are going on, or grant opportunities, or other TA opportunities within the TA network, including this series of webinars. But want to also be respectful of folks' time. And the link to the survey just went up as well. So as Lauren said when she kicked us off, we're really trying to learn more from you guys about the spaces within the early childhood systems that you are occupying, and what your sort of prime questions are, and how we can pull in experts in the field that really speak to where you guys are and what your work is, and really de-silo some of the systems in early childhood.
And thank you for bearing with us through our technical difficulties and our burdens with I think what is probably now a 1/4 inch of snow.
We're a little faint of heart here in the Northeast.
And Rhode Island is still making fun of us.
Yeah, I think we picked 2 state examples that both have far more snow records than we ever do. So not a good day to have that happen.
But please bear with us. We look forward to you all joining us next month, and thank you all for your time.
Thank you guys so much. We'll be in touch.
Thank you.